Good evening, everyone. Now we'll start a session on hand surgery. We will be discussing on the nerve injuries associated with skeletal trauma in the upper limb. To discuss on this topic, we have with us as our chairpersons Dr. Punya Patni Madam and Dr. B.L. Kumar Sir. He will be joining soon. We have two eminent national faculties from outside, Dr. Anil Bhatt from Manipal and Dr. Abhijit Vaigaonkar from Pune. They will be joined by Dr. Amit Vyas, Dr. Vineet Arora, and Dr. Aviral Gupta. In this session, we'll have two small talks followed by case discussions. The first talk will be on how to approach a patient of nerve injury associated with skeletal trauma by Dr. Abhijit, followed by the talk on relevant investigations in such cases, what and when are they to be done. So I'll first invite our first speaker, Dr. Abhijit, to share his keen and give his talk on how to approach a patient of nerve injury associated with skeletal trauma. Dr. Abhijit.
Yeah, thank you very much for this opportunity. And my task today is to speak about the approach to the patient with a nerve injury who presents with a skeletal trauma. And this is a very common condition, as you will all concede. And I have no conflict of interest. So this is a very common fracture that I'm sure that everyone will see in clinical practice sometime or the other, and in every stage of clinical practice, be it junior residency to a senior consultant's post. More often than not, we are engrossed with fixing the fracture, applying a plaster, and a lot of times it's a above elbow kind of a slab or a plaster. And when the fracture is fixed, and then the patient returns to the clinic with, oops, a wrist drop. And this is something that might have been missed at the initial presentation in the frenzy of dealing with the fracture. So here is another case where this was a 13-year-old girl who presented with a fracture, but somehow, fortunately, the treating surgeon noticed that the child had a wrist drop. This was a transverse fracture with warranted fixation, and they just decided to take a look at what's happened to the nerve. And as you can see here, the nerve is entrapped in the fracture fragments. And here you can see the nerve being completely freed. This is the fracture line here, and the fracture has been fixed, and the nerve should recover because this is a child. Now, when a patient presents to you with a very obvious polytrauma, multiple fractures, and a limb that appears pretty much paralytic or like this, it doesn't take rocket science to imagine that there is something going on with the nerves and the limb is paralytic, and then you would pay attention to the nerve injury in addition to dealing with the skeletal injury. So with that brief introduction, I would now like to start a topic on how to approach a patient. So we all understand and know that there is a higher incidence of peripheral nerve injury associated with fractures in the upper limb as compared to those in the lower limb. However, because little clinical information is available, we do not know what the best course of treatment is. And this is often highlighted by the case that we discussed about humerus fractures associated with radial nerve injuries. But in this talk and over the next few minutes, we'll try to understand how best we could deal with these injuries. This is a very interesting paper which was published in Journal of Trauma, where they looked at more than 5,000 cases, and all patients were young and predominantly male with a high energy motor vehicle accident or motorcycle accidents. And what did they find? That the radial nerve was involved in about 10% of humeral fractures, ulnar nerve injuries was about 4%, and median nerve was about 2%. And fractures of the radius and ulna were associated with either ulnar nerve injuries or median nerve injuries in a lesser frequency. How do these statistics compare when we look at lower nerve injury? Sciatic nerve injury is involved only in about 1.1%, and femoral nerve in less than 1%. So in comparison, if you look at upper limb nerve injuries, they are more frequent, they are more involved. This particular paper had a fallacy wherein they did not include brachial plexus injuries and they did not look at lumbosacral plexus injuries. Another paper by Delat again highlights what happens with shoulder dislocations and humeral neck fractures. Again, a very common clinical scenario. You will understand here from this slide that there's a 45% incidence of peripheral nerve injury, which was confirmed on electrodiagnostic studies. And the axillary nerve was the most frequently involved nerve in shoulder dislocations and neck fractures. However, there is a very different age group here, and these are usually low velocity injuries. So patients more than 65 years of the sixth decade, approximately 54% of this cohort of 101 patients involved patients who were more than 65 years. The third scenario, the most common clinical condition we see is that in children where there are supracondylar fractures and any of the three major nerves may be involved. And again, the highest frequency is that of the radial nerve, followed by the median and the ulnar nerve. So what is the natural history? What are the guidelines for management whenever we are presented with a patient with a skeletal injury and an associated nerve injuries? So most patients with closed fractures have neuropraxia without an actual neurotomesis or an exontomesis, and more often than not, their prognosis is favorable for spontaneous recovery. However, the fallacies are that in the acute setting, we are faced with a very difficult clinical judgment as to how accurate we are in defining the severity and the extent of nerve injury. And usually, when there are no signs of recovery up to about 6 months post-injury, both on clinical or on electrodiagnostic testing, the dictum is that the patient should undergo exploration to maximize the likelihood of return to function. So these are more often than not the guidelines. However, there are certain nitty-gritties of this, and we'll just deal with that in a bit. So what is the approach to treatment? 85% will have a spontaneous recovery rate, as was documented and reported by this author in Injury in 1985. And their study said that skeletal injury is managed at the discretion of the surgeon, just like we saw in the previous case, where the humerus fracture was a transverse fracture, an inherently unstable fracture in a child requires surgery. So why not take the opportunity to verify what is happening to the nerve? So skeletal injury is managed at the discretion of the surgeon, and the extent of exploration should be limited to that which is necessary in order to ensure that the nerve is free of the fracture site. So this is exactly what we saw in the case discussion at the outset of this particular talk. So while we wait for the spontaneous recovery to occur, it is extremely important that the joints be splinted, especially in the functional position. Passive and active range of motion exercises, active for the muscles that are working or the joints that are spared, and passive for the joints that are paralyzed, should be initiated as soon as fracture management allows or fracture care allows. And this is especially to prevent any stiffness, so that when you are perhaps thinking about nerve surgery, the condition should be optimum. The recommendation for electrodiagnostic studies is that we should get the first study at 6 weeks, which is the baseline study. And then the follow-up study is done at 12 weeks. Someone's mic is working. Can they be muted, please? Yeah, thank you. So the electrodiagnostic studies are initially done at 6 weeks. And this is the baseline study. Please do not advise electrodiagnostic studies at the get-go, because they will be fallacious. Someone's mic is working. Please mute. Thank you. So here is an algorithm that will again help you understand how we go about dealing with Can the mic be muted, please? Thank you. All right, so coming back. So now when we do the follow-up study at 12 weeks, it is important to then determine if there are some signs of recovery. What are these signs of recovery? There are large polyphasic motor unit potentials, and these patients will usually recover, and whatever function is not recovered is best addressed by tendon transfers than by a nerve surgery. If there are no or few signs of recovery, which is highlighted by fibrillation potentials, a positive sharp wave, and a diminished or absent MUP, then you subdivide these patients into three groups. The first group is a pediatric age group showing little evidence of recovery, and the second group is adults with radial nerve deficits, and the third group is adults with deficits other than the radial nerve. So this just helps you manage these patients in a very nice manner. So children are basically defined by skeletal immaturity. They should usually be observed up to about 9 months before exploration or reconstruction, because there is almost a 95% recovery rate within this time frame. And then if these children do not recover at around 9 months, they qualify usually for tendon transfers. Now, adults with radial nerve palsies, this is the second group. They may be expected to recover up to 90% at 6 months. In patients who do not recover, you have two options. Either you explore and repair the nerve, or you do tendon transfers. And there is a lot of controversy regarding whether you should do a nerve repair or a tendon transfer. So this is a conundrum to the treating patients. Even the most experienced nerve surgeon will face this dilemma. So the new protocol is to do something called as an internal splint, and then wait for the recovery to occur, and thereafter we do either tendon transfers or a secondary nerve exploration and repair. The third group is one where you have a nerve injury other than the radial nerve, and the treatment of this group is based on the premise that certain nerves will recover better than the others. And this comes from the study of Roganovich, which is mentioned on this slide. The femoral and the musculocutaneous demonstrate excellent recovery potential when repaired within 24 weeks of injury, whereas the median, the ulnar, and the tibial nerves demonstrate relatively poor outcomes when repaired later than 24 weeks. And peroneal nerve, irrespective of when it is repaired or explored, has the worst prognosis. So to answer this, or to address this dilemma, there is a very neat astute that we can use, and this is the technique of David Klein and Happel. David Klein is a very famous neurosurgeon, and what they described is stimulating the nerve proximally and recording the nerve action potential distally in the injured segment. And 93% of injuries which were addressed by this particular technique did have excellent outcomes. How do we do it? So they are not just any nerve stimulators. They are a three-pronged, as you can see, 1, 2, and 3, and a bipronged. So this is the stimulating nerve electrode. This is the recording electrode. Now, in this particular slide or schematic diagram, this is the stimulus. This is the recording action potential, and you can see that there is a spike, which means that this is a neuroma in continuity, and therefore only neurolysis is sufficient to have outcomes. Now, in this schematic diagram, the stimulating electrode, the current is going across the neuroma in continuity, but there is no action potential here on the recording electrode, and this will require an excision of the neuroma and cable nerve grafting. So this just helps you in determining how to approach. So this is the last slide, couple of slides now, and this is an algorithm as to how we should approach a patient with a skeletal injury with a nerve injury. This comes from the paper which was published in the JAAOS, and the algorithm is such. So if you have a fracture that requires internal fixation, you would then go ahead with an intramedullary fixation or an external fixation, and then you would explore the nerve through a limited exposure. If an open reduction and internal fixation is required, you have a very good opportunity to look at the nerve, and it is usually rare that there may be a complete transection, and an extensive dissection may assist with repair if there is a transection. If the fracture does not require an internal fixation, then you get baseline electrodiagnostic studies done at 6 weeks post-injury, and at that particular time, if there is recovery, you observe the patient continuously for another few months. However, if there is no nerve recovery, that is where you start to have the dilemma. And at this stage, you repeat the electrodiagnostic study at 12 weeks. And like we discussed earlier on, then you divide the patients into 3 groups. If there is recovery at this stage, again, you observe, and these patients may require a late tendon transfer if the functional recovery is not optimum. However, if there is no evidence of recovery in an adult, you have two subgroups, those with radial nerve injury, those with injuries to nerves other than the radial nerve, and the pediatric age group. In pediatric age group, you wait for almost 9 months, and if there is no recovery, that is when you go in for tendon transfers. Now, I repeat that if other nerves are involved, other than the radial nerve, based on what nerve is involved, you would then consider either an exploration or repair. You would consider tendon transfers. And again, there are multiple factors: patient age, comorbid conditions, and so local skin condition, associated skeletal injury, and so on and so forth. And it is extremely helpful to consider intraoperative electrodiagnostic studies if you have the facility to do so. If there is a radial nerve, usually tendon transfers work better, so people will argue against a nerve surgery which is more demanding and challenging. So for an orthopedic surgeon, tendon transfers are perhaps the best way out of these injuries. With that, I thank you and appreciate the opportunity to speak here. Thank you.
Thank you, Dr. Vijit. It was a very informative talk from you. We had a good point. So now I'll invite Dr. Anil Bhatt, sir, to give his talk on investigative approach to these type of injuries.
Good afternoon. I am Dr. B.L. Kumar. I'm a bit late to join your session.
Good afternoon, sir.
Yeah, good afternoon to everybody, and welcome to this midterm ROSACON. You just continue with that. Just want to say that.
Okay, thank you.
Yeah.
So thank you, Dr. Saini and ROSACON organizers for this opportunity. My talk is basically on investigations towards the same kind of injuries. The scope of investigations, I need to clarify that basically the clinical examination is the gold standard always in nerve injuries, and investigations are complementary to this, and which basically helps us in decision making of what is the status of the injury and the progress of the recovery itself. So my scope of this talk is investigations in acute injuries, chronic injuries, and closed injuries. What modality of investigations to look at the anatomy, the physiology and pathology of the nerve, and the timing when it has to be done actually. Right. Now, we do get as orthopedic surgeons a lot of times consultations in the triage with these kind of polytrauma patients, and they will be asking us to see what has happened to the limb. There could be so many possibilities here. There could be vascular injuries, compartment syndromes, and there could also be nerve injuries. So one of the things to be kept in mind would be a nerve injury. And probably in this situation, I would suspect a brachial plexus injury. The entire limb is not moving. So what are the relevant investigations on day one of injury when these patients are being asked for us to be seen? The associated skeletal injuries, the x-rays are the basic things. We would look at any injuries around the shoulder and in the arm itself. But one of the things, if at all you suspect brachial plexus injury, would be a chest x-ray with deep inspiration to look for any diaphragmatic palsy like this to check for phrenic nerve palsy. Cervical spine x-rays are important, and if there is a doubt about it, a CT scan would be helpful on day one. But otherwise, nothing more probably could be done on day one. Some x-rays when you see, that should alert you to possible nerve injuries itself. If a patient somebody comes with an x-ray like this, we should be suspecting axillary nerve injury, which means the message here is to extrapolate the soft tissues always on the x-ray and see which nerve is close by for these kind of injuries. Radial nerve is a very common injury, but then we should know where is the danger zone when we see these kind of pattern of fractures. We need to know where is this red one which is marked as a danger zone for the nerve as it travels down here. So probably you should suspect the nerve injuries and then again go back to the x-rays for this. Again, supracondylar fractures very commonly associated with median nerve injury in an extension type, the anterior interosseous nerve, or the ulnar nerve in the flexion type itself. And in a Monteggia fracture dislocation, most of the time is the posterior interosseous nerves. And as Abhijit said, most of them are neuropraxia and they would recover here. A very badly comminuted distal radius and ulna can have median and ulnar nerve involvement. So if we come back to the first case, what is the next set of investigations? So as sequences when they do the MR itself. Now, coming to electrodiagnostic studies, the three basic questions it answers is what is the level of injury, what is the type of injury, and is the nerve recovering or not. Sometimes there could be double lesions, and in brachial plexus, whether there is any root avulsion or not. These are the things. And the optimal timing, as I said, depends on the clinical question, what we are looking at, those three questions. If somebody does an NCV at immediate to 7 day, immediate or within a week, it basically probably tells whether it's a complete injury or incomplete. Neurotemesis is definitely can be seen. There's absolutely no conduction both proximally and distally. Then we can tell it's, but we can't really tell it's neuropraxia or axonotemesis. So the best of the information comes from by about 4 weeks when the Valerian degeneration is started and established, and it is over, and then regeneration has to start. That is the time you need to do your NCVs. And if done by about, when we start following these patients by about 3-4 months, what we are looking at is reinnervation. So this recovery precedes clinical recovery by about 2 months. So this is the time when you have to follow up these patients with nerve conduction study. Again, an example of neuropraxia of a radial nerve injury. If you see the proximal side, there is decrease in the amplitude here, and the conduction falls on just one side here. And again, the fall in the amplitude at this point here. But then distally, it's conducting. So it tells definitely that it is a neuropraxia because it is conducting distally. Now, EMG and axonotemesis, again, nerve is excitable. So that is where you have to use your EMG, where fibrillations and positive sharp waves are seen at about 3 weeks like this. That is a Valerian degeneration. By about 3 months, you start looking for reinnervation, which means basically the giant action potentials and polyphasic action potentials here like this. So this is the way we need to time exactly when to do these kind of nerve conduction studies and EMGs. So the key instrument, especially in nerve injury, is EMG at subsequent visits after you have done your baseline NCV or EMG, because the EMG will then start picking up any reinnervation at the most proximal muscle. And this recovery always precedes, again, clinical recovery earlier. And if there are no signs of recovery at speculated time for the level of injury, then probably that is an indication for explorations. Classic example, again, is radial nerve in the groove. In this case, if you see, it takes about 140 to 180 millimeters for this to the distance around the fracture site for it to reinnervate the brachioradialis, which is the first muscle, which means about 180 days, about 6 months. So the recovery of brachioradialis must happen by about minimum 6 months from injury if it was an axonotemesis. Neuropraxia will recover by about 6 weeks. Neurotemesis, we know it's an open injury. So our doubt always is towards axonotemesis. What's happening there? So we can still wait till 6 months. And then we have additional 1 year because the neuromuscular junctions take about 18 months to degenerate. So we still have 1 year for other muscles. But by about 6 months, if it is not recovering, then there is an indication that yes, it might have to be explored. Or you wait further, then probably you can go for tendon transfer between 6 to 9 months. This is how the decision has to be made in this. Now, is there any role for any intra-op investigations? Again, classically, when we plate these fractures, when we go to the posterior approach and see the nerve there, either it's contused or it's stuck between the fracture fragments. And as Abhijit said, we have to free these fracture fragments when we put the plate here and make sure the nerve is not caught anywhere between. But one other option is an intra-op nerve stimulation can be done for these patients. But this is not radial nerve. This is brachial plexus, actually, the anterior and posterior divisions of upper trunk, which is being stimulated. So we can see the action of deltoid here for the anterior divisions here. And if you go distally here, we can see the action of the biceps when we stimulate the posterior divisions. So the same thing can be done even for a radial nerve intra-op when we are doing a plating of these and see whether the conducting muscles are stimulated or not. Now, when you come to the chronic or late presentations, again, a soft young patient, polytrauma patient, presents at 6 weeks with a claw hand like this, absentinal side, and the operating surgeon had documented that the ulnar nerve is in continuity at the time of surgery and he's closed it. These are the x-rays. He had multiple fractures here like this. And then NCV, when he came at about 4 weeks, showed absolutely no excitable, motor action potentials or sensory action potentials. So basically, we want to know what is happening. We know that there is a Valerian degeneration, and the surgeon said the nerve is intact, but then there is no recovery as such. So what do we do now? So should we wait? Should we investigate further? Or should we explore? This is the question which we always have in mind, and we need to give the best to the patient in today's scenario. That is where another investigation comes in, which is basically an ultrasound. An ultrasound is very versatile because it gives excellent visualization of the fascicular architecture and can be used in a dynamic mode. That's a median nerve we are showing. It's in near the carpal tunnel here, which we are seeing for a patient here. We can do the measurements, and the patient can flex, and now patient is flexing and extending his wrist. And when we can see what is happening to the nerve. So the dynamicity comes in an ultrasound, which is not there in the MRI. So that's very important. So the normal nerve looks like this bundle of straws like this. In axial view, it looks like it's got a honeycomb appearance. Now, any implant which can cause damage. Here is a K-wire impinging on the ulnar nerve here. and then that fascicular architecture is lost here. And another example, this is a digital nerve which has been transected here. This is another example of a neuroma here. So these are the things which can be very nicely visualized in an ultrasound. So what we did for this patient was we decided to investigate further. We saw that the fascicular pattern of the ulnar nerve is damaged here, 3 centimeters proximal to the guidance, because surgeon said it is intact, the nerve is intact, but what's happening inside the nerve, right? That is what is being picked up by this ultrasound, which means there was an evidence of significant nerve injury because of partial epineural disruption, though it was in continuity. And that's what was actually seen intraoperatively also. Extensive neuroma and continuity, multi-level, which is very, very actually got very poor prognosis. Then intraop, you do under a microscope, you do a neurolysis, and then you do electrical stimulation. If there is no response, that's what happened in this patient. 3/4 of the nerve or a distance of 2 centimeters was completely fibrotic, which means you have to go in, dissect the neuroma, and put in the multiple sural nerve grafting. This is how the decision is made intraoperatively. So we decided to explore because one, clawing. Second, there was a nerve conduction which showed a point block at the wrist region. Third, USG showed clear evidence of epineural disruption. Fourth, intraoperative nerve stimulation further guides neurolysis or nerve grafting. So at the end of 15 months, this is the result. So completely recovered nerve for these patients. So in summary, what I would like to say is investigations complement clinical examination and follow-up. And you always extrapolate soft tissues and X-rays looked at, see what nerve is close by and probably what should do. Timing of investigations is crucial. Doing MRI or NCV on day 1 or day 2 is absolutely useless for clinical decision making. Use combination of methods, both pre-op, intra-op, and post-op to see and progress of this nerve recovery. And dynamic examination, especially in ultrasound, adds value to the whole thing. Thank you so much.
Thank you, Dr. Anil, for the very informative talk. Now we'll start up with a case discussion. We have kept a few cases, and I'll invite Dr. Amit to start up with his first case.
Thank you, everyone. I will start this case presentation and I will ask by name. Then please unmute and respond quickly because we have very less time. So, this 20-year-old male, he had this X-ray, which is showing fracture humerus. Dr. B.L. Kumar sir, what precaution you will take care while managing this type of humeral fracture?
So this is a comminuted fracture of lower fourth of the humerus, and most likely the nerve which involved in this case is a radial nerve. So first thing that you have to take care is about the spike of bone, which is while dealing with type of bone fracture, you have to handle with care because sometimes there may not be injury initially, but when handling this type of fracture or pulling down, it may lead to injury to the nerve. So you have to be careful, handle with that. And then when you do surgery for this type of fractures, first you establish whether the nerve injury is there or not. If it is not there, then this type of fracture needs internal fixation, what I believe is by means of plating. Because
thank you very much, sir. So very well taken points that you should have clear suspicion that there may be radial nerve injury. Dr. Abhijit Vaigaonkar, sir, any extra point you want to add? Please unmute and tell. Sir, please unmute yourself.
Yeah.
Can you hear me now?
Yes.
So I think the first suspicion would be that of a radial nerve, as was
Somehow it is to stop.
Some issue with connection, I think.
Okay. Anil Bhatt, sir, can you comment?
Right. So if it was on day one, basically, obviously, the documentation is very, very important as to what is the neurovascular status of this patient distally. And then, of course, as Dr. Kumar was telling, that we need to plan for obviously, this requires an operative kind of management. The approach, again, is a posterior approach. And during surgery, it's very, very vital that you have a documentation, again, of what is the status of the nerve. And if the nerve looks in continuity, there is some contusion, some bruising, it's okay. But if patient had a wrist drop, then you would, if there is a facility, you would do a nerve stimulation. Otherwise, you can always just document which area the nerve is actually going in terms of which screw it is crossing, and document in the OT notes that this nerve is crossing between the 4th and 5th screws, and make sure that document is there for any further future intervention by any surgeon later on who comes in.
Okay.
Or even if it recovers, that during implant removal, sometimes this information is very vital.
Very valid points were pointed out by all that we should be very careful while doing this fracture fixation. Radial nerve should be explored, and the condition of the nerve should be documented. Okay. So unfortunately, this patient, his fracture humerus fixation was done by the posterior approach, and patient himself noticed. So this point was pointed that every time we have to document the things. So at the 6th week, he noticed that he is not able to extend his wrist and finger. And somehow it lingered on. Then he presented to me at 4 months with the same condition. So at this time, can Dr. Abhijit, can you tell us that what will be your management plan at this time, or any further information you want?
So first and foremost, did the patient have the palsy before the fixation was done at the time of injury, or was it after surgery?
Unfortunately, it is not mentioned. So
Right.
we don't clear.
Yeah, I think this is a very important thing to document whether the palsy was present at the time of injury, because then you can usually wait and then, like I just spoke about in the talk, you could wait and get an EMG NCV done at 6 weeks and then at 12 weeks and then decide the future course of action. However, if the nerve palsy happened at the time of surgery or after the surgery and there was no palsy at the time of injury, I think yet you could wait for some time. An ultrasound examination provides a fantastic opportunity. It provides a window to study the nerve and then decide if the nerve is transected or not. Again, there is a lot of controversy whether you should do a primary nerve repair or a tendon transfer, but most surgeons would lean in favor of tendon transfers.
Okay, very well said points. So at the 4 months, as there was patient presented to us, we did full clinical examination of the patient, and surprisingly, we found that brachioradialis is acting. It is grade 4, and his ECRL also showing recovering, and there is no ECRB, ECU, EDC, all were 0. So now what will be your management? Can anyone quickly comment?
I think you can continue with your conservative management, splintage, and rehabilitation.
Can you tell us what will be the conservative management at this site, at this stage of treatment?
Splint the extensor in functional position, document your first clinical examination, and when you further follow up the patient, again examine and then note down the recovery. If the recovery is going on, continue with the recovery pattern, then it is well. If it doesn't, then you...
Which type of splints you want to use at this stage?
I think wrist in 20 degree of extension, and you may support the fingers along with the wrist, or you can just splint the wrist because the wrist is recovering. So you have to splint wrist first and then the fingers and thumb.
Okay. So for the daytime, just cock up the wrist.
Cock up the wrist.
In the night time, long cock up. No, you want to say the same thing?
Dr. Abhijit, you want to say something?
Just had a question about nerve stimulation as part of the observation period. So do you use nerve stimulation while you're waiting for the recovery to occur?
Nerve stimulation. Okay, sir, well taken.
Two other things can be added with electrical stimulation and also a vitamin B12 with this for the patient. That is a part of the non-operative management till the recovery happens. If patient can do it himself at home, we always give them a kit, a small kit, which is just costing about 2,500 rupees. They take it and they do the electrical stimulation themselves at home and continue with that. They don't have to go to a therapist every day for these kind of things.
Yes. So we did the same thing, supplemented the methylcobalamin, and we used these splints at this time. Dr. Anil Bhatt, sir, can you comment on these type of splints?
Well, sometimes, see, at least for your case, I don't really prefer a splint. Maybe just a static occur splint to the wrist. You said ECRL is grade 4 already, right? So too much of splinting, again, putting them all these into splints sometimes is actually not a good thing for the patient. We allow them because they have their opposite hand. They can keep doing their mobilization nicely and give only, as you said, maybe in the night we give a splint for them. Otherwise, putting them into too much of complicated splint like this sometimes can cause other problems and complications in terms of stiffness and other things. And so I would really not prefer very complicated splints. Basic splint is good enough for most of the time.
Very well said that this type of splint can be avoided because we just need to support the wrist only. So the role of physiotherapy is prevention of contraction and strengthening of the recovering muscles. So surprisingly, the patient started showing recovery after 2 months, and then there was full recovery. So this documentation is also important, so we can know what was the condition previously. So this is the pictures. He started showing recovery, and later on there was full recovery. So any point want to be added at this stage, or shall I proceed for the next case?
Yeah, Amit, one point is EPL is the last one to recover. So you need to tell the patient the thumb will take some time to recover. They always are worried about the thumb. So EPL is one of the last muscles to be innervated by radial nerve. So it will take some time, the posterior intraosseous part of it.
Okay,
so I think another point is that people, if they see this wasting of the forearm and hand, so they start trying to increase the power with any other methods or like these. But just you have to give rest. Otherwise, the extensor may not recover fully. So it will take more time. So just inform the patient that you have to give some rest to these tendons, these muscles, and not try to do more and more exercise to prevent.
Okay. So I will go to next case. This 24-year-old male, he was treated for humerus fracture by plating, and he presented to me at 4.5 months. According to patient, his radial nerve palsy was post-operative. He noticed in post-operative period there was, as this is a consistent problem, that surgical notes was not showing any condition of the radial nerve. And so at 4.5 months, what will be the your management protocol, or you want to know any further detail about the management, the clinical condition of the patient? Madam, can you comment, please?
See, at 4.5 months, even your most proximal muscle is not showing any recovery. Mm-hmm. I would really go in for further investigation to confirm. Maybe an ultrasound would be the first investigation, so that you can see the continuity of the nerve. If there is a breach in the continuity of the nerve, I would really not go in for any further electrodiagnostic studies and go in and explore the nerve.
Okay. So very well said that as proximal muscles was not showing any recovery, and so at 4 and 5 months, no recovery on proximal muscle. Surgeon was also not aware about the condition. Incision is anterior. So, but ultrasound is not available at all the places. Is any role of electrodiagnostic study at this stage? Dr. Anil Bhatt, sir, can you comment?
Sorry, Amit, I don't agree that ultrasound is not available everywhere. It's just probably the expertise. And so if you have your own ultrasonologist, maybe if you're practicing in an area, you can ask him to do more and more of this. I also see a fracture fragment in the X-ray posterior aspect, which is quite big fragment. Did he have any head injury or anything?
No, he didn't have any.
Okay. As you pointed out rightly, incision is anterior, very difficult to damage the nerve except the distal part of it. So yeah, and I would definitely ask for a nerve conduction study and to see what is the level of injury and what is happening at that. Clinically, again, I would like to check for the tinal sign and if at all there is any changes there also. All these, to add up everything together, as Madam said, ultrasound with an NCV, clinical examination and tinal sign, and to rule out if there's any additional fracture fragments compressing the nerve, because the incision was anterior. So all these should be added up together.
Any specific thing you want to point it out in the electromyographic studies?
Basically, I'm looking at the reinnervation at the brachyradialis level, if at all anything is happening. Yeah.
Yes. Because most probably it should have started showing reinnervation. And as you told in your talk that it picks up 2 months prior to the clinical recovery. So the same thing we did. There was EMG, it was showing interference pattern in the triceps, and there was sign of denervation in brachioradialis, and there was zero conduction in both sensory and motor nerve conduction studies. So Dr. Abhijit Vaigaonkar, can you comment at this stage, what will be your further step?
So I think at this particular time, it's evident there is a nerve injury and there is not going to be any further recovery. We are at 4.5 months. This particular patient very likely will require nerve grafts rather than nerve repair and just a neurolysis. I think I would lean in favor of tendon transfers. I would perhaps do an internal splint, that is to say a pronator teres to the ECRB. Take a look at the nerve. If I think that the nerve recovery might give him function, it's especially for the EDC, because tendon transfers will not give independent finger extension. I would look at the nerve, do a nerve surgery. If the nerve repair,
means you want to explore the nerve,
yes,
or you want to directly go for the tendon transfer?
No, I would do only one tendon transfer, pronator teres to the ECRB, and then do the nerve surgery. Wait for the recovery. If it does not recover, I would have counseled him earlier on that he might need a second tendon transfer for the EDC and the EPL.
Can you comment that at what time you will directly go for the tendon transfer?
I think I would wait for about a year after the nerve surgery. And of course, with clinical examination coupled with electrodiagnostic studies, if the nerve does not recover, that is when I would do a tendon transfer.
So I think everyone is agreed that we will go for the exploration of the nerve, no?
Sorry to intervene, Amit. You need to finish it fast.
Okay. So we found that radial nerve was found entrapped within the plate. So, Dr. Vineet Arora, can you comment on this?
I think at 4.5 months, the plate might have damaged the nerve underneath. So, release the both ends, and then you can see if the nerve is repairable or maybe need a reconstruction. And the second thing is internal splintage and transfer can be done.
Okay, Dr. Abhijit Vaigaonkar, I did the same thing. I removed freshened the both ends of the nerve, and I found that nerve was, we were able to approximate the nerve at 60 degrees of elbow flexion. So what will be your protocol now?
I would never do that. If the nerve cannot be repaired in elbow extension, it should be grafted. Never repair in flexion, because I think that's criminal to do. Nerves will not withstand any tension. Yes. So the radial nerve has to be repaired with the elbow in full extension, not in flexion, because the moment you start extension, it's all going to give way. So I would not do this, but I think.
But sir, do you have any experience on this, especially about the radial nerve?
Yeah, I mean, as Abhijit said, no tension for a nerve. So it's already there's a damage. So you are giving a one-time surgery for the patient. So which means we should not have further damage to the nerve in any way. So if there is a lot of tension, then definitely it's worth going and putting in a graft if you're planning to do a proper resection and reconstruction, and make sure that they're relaxed completely, because radial nerve is a pure motor nerve and it will recover nicely given a chance. So again, if you put it in 60 and then you want to stretch it out later, it might still cause some amount of damage to the nerve ends itself. So rather than that, we go towards a graft and then wait for it when we do the reconstruction.
Okay, point is well taken. Usually we don't do this, the things, but in case of radial nerve in this particular patient, because there was already 4.5 months. So at this point, I searched the literature also. Then I found various authors have suggested that direct repair of radial nerve are having better outcomes. So in this patient, I cheated myself and did the radial nerve repair at 60 degree of elbow flexion. So, and for 6 weeks, I immobilized the elbow, then gradually extended the elbow, and somehow I was able to get the results.
So the direct repair point is correct. I mean, anytime the direct repair is always the best. When the nerve has to cross two junctions, obviously the results are compromised. But what the point we were trying to make is the amount of gradual distraction later which happens. So if you're not careful on that, you might lose out on the direct repair. That is the point again.
Okay.
Right? Yeah.
So I would like to interrupt in between. Vineet, you can please share your case very fastly because we are having very less time now.
Okay.
Okay. Shall I stop or just the conclusion part I should run?
Yeah, you just stop.
Okay.
We'll take Vineet's case and we'll end up the session now.
Okay, sir. Thank you.
Good afternoon, everyone. I am going to present a case where the 20-year male patient having a history of fall from bike
Good afternoon, delegates. Welcome to spine session of midterm ROSACON. I welcome Dr. Ashish Jaiswal from Chhattisgarh, who is our national faculty today. We also have with us Dr. Chirayu from Udaipur, Dr. Girish, Dr. Namit, and Dr. Praveen from Jaipur, Dr. Darshan from Kota, and Dr. Naveen from Jodhpur. So we are going to discuss about vertebral compression fractures in this session. So just to start some introduction, we know osteoporosis is going to be a big problem for all orthopedic surgeons in coming days as our demographic profile of the country is changing. Vertebral compression fractures are very common manifestation of osteoporosis along with fractures of hips and wrist. And usually these are stable anterior wedge compression fractures and which may be caused by physiological loads. The problem is going to be big as we see with changing demographic profile, and a lifetime risk of 16% in women and 5% in men is expected. Most of these fractures are actually asymptomatic, but about 1/3 of them are painful, which are usually managed conservatively and become asymptomatic in 6 to 12 weeks. But the remaining patients are actually bothered significantly by this pain. So usually osteoporotic vertebral compression fractures are considered to be benign and self-limiting type of injury, and not much emphasis is paid usually by general public as well as
doctors on this aspect, but actually they are not so benign. They can cause significant pain. They can induce osteoporosis by prolonged rest. They can precipitate recurrent fractures. They can cause kyphotic deformity, which can result into pulmonary dysfunction or GI dysfunction. And it also has significant psycho component also, like the patient can go into depression, and all this can cause increased mortality. Actually, these fractures, just like intertrochanteric fractures, sentinel signs of failing health, and with increase in mortality rates after development of these fractures. Fracture usually creates a kyphotic deformity, which increases the chance of second fracture because the mechanical axis actually moves forward and increases the load on other vertebra. One vertebral fracture in thoracic area can cause 9% decrease in pulmonary vital capacity, and it can also cause decreased abdominal space if it is in thoracolumbar area with resultant metabolic effects, which we can all understand. The pain after vertebral compression fractures can be because of the fracture itself, can be because of the pseudoarthrosis formation, it can be because of altered spinal biomechanics, which results in muscle fatigue and ligamentous strain. So we have to do a detailed clinical examination, take a detailed history. The X-ray is usually the first investigation which we all advise, and most of the fractures are picked on X-ray. But the most common problem in these patients is that we are unable to usually judge the age of fracture by seeing an X-ray. So usually an MRI is also ordered. Well, take the opinion of panel. What are their indications for ordering an MRI? Rayu.
I would definitely see at the history of the patient. And if the patient has a history of any trauma or anything, then it's okay. Otherwise, if I'm looking at osteoporotic fracture, definitely an MRI is mandatory. It is impossible to see on an X-ray whether this is a new one or an old one. And in addition, I think you can get a scout film so that you can actually look for other level fractures if there are non-contiguous levels involved. But MRI is definitely yes. Go.
So yes, a very important factor. Never miss skip fracture, what we call non-contiguous type of fracture. Naveen, what MR sequences will you order when you are ordering an MRI for a suspected vertebral compression fracture patient?
Can you hear me? Can you hear me, boss?
Yeah, Naveen, please.
So the routine sequences T1, T2, but along with them, specifically the stir images, which will help us to find out the edema in the body, the fat suppressant images.
So this is one case example. As Naveen told, that we need to identify the fracture acuteness. So if we see in this image, we can see two fractures here. One is in T11 and the second is in L1. But as we see the first image shows the T11 signal is normal in all the three images. So basically the T11 fracture is an old healed fracture, while L1, the rightmost image, is basically the star image, which is showing significant edema. The middle image is T1 weighted image, which is again showing significant hypointense signal, which actually signifies edema. So if you are treating this patient, basically we need to treat only L1 fracture, not the T11. Do you agree, Naveen?
This is the basic reason why we need the stir images, because both in T1 and T2, the fractures, many a times even the acute fractures will show hypointensity. When we see stir images, we can always look for edema, which will help us to find out what is the age of the fracture, whether it's a new fracture, whether it's an old fracture. It becomes very important while treating these patients.
Darshan, do you find any role of bone scan in routine evaluation of these patients?
No, if history is not doubtful, means if in history it is a pure trauma, then bone scan or other scans are not important. If in a patient with a previous history of some other places, some carcinoma or adenocarcinoma, then yes, we can find the other areas of metastasis. But for the routine patient with undoubtful history of fall, not required.
Yeah, so important thing is bone scan may be required when we are evaluating other things like metastasis, myeloma, or carcinoma prostate type of things, but not routinely required. Also, it's not easily available at most of the places. However, it may pick some fractures when even MRI is normal. So the treatment objectives for vertebral compression fractures are pain relief, which should support the patient for early return to normal activity. We should try to attempt prevention of development of kyphotic deformity. We should look for prevention of neurological deficit due to cord compression by bony fragments. And we should never forget that we also need to treat the basic cause of this fracture, which is osteoporosis. So very, very important is to look for osteoporosis management, which is going to be a long-term treatment for these patients. So treatment option for vertebral compression fractures can be conservative, it can be surgical, or it can be percutaneous vertebral cement augmentation, a sort of minimal invasive type of thing. So I would request Dr. Namit to start his presentation about conservative treatment of vertebral compression fractures.
Lalit.
Yeah.
I would like to add two more points. Like in X-ray part, while investigating, we should always advise for standing or sitting X-ray. That is also important in addition to our routine X-rays.
Yeah. So what do you exactly look for in standing X-ray?
Standing X-ray, what happens in routine supine, sometimes you will miss the fractured vertebra. So you will get some kind of active dynamic compression. So that is one thing. And flexion extension also helps us to look at the mobility of fracture site. And sometimes it can elaborate some vertebra which is fractured, but it is seen normal in our supine.
That
Second,
is very...
bone scan part. Whenever MRI is contraindicated and we want to find out whether it is a fresh fracture or old fracture, bone scan is of help, besides ruling out other pathological.
So bone scan and CT scan can be useful when a MRI is contraindicated, like a patient with pacemaker or something like that. And yes, we totally agree that any occult instability can easily be picked by dynamic X-rays. So that is a very, very valid point. Namit?
Yes, sir.
Please start.
Good afternoon, everyone. Treatment of osteoporotic fracture is a difficult task because patients, mostly old patients having multiple comorbidity and associated with risk of prolonged bed rest. And in these cases, surgical patient having poor fixation hold and disturbed fracture morphology and sometimes associated with neurological deficiency. And osteoporotic fracture need long fixation, so it need long surgical duration associated with more surgical trauma and blood loss. Management, traditionally we involve bed rest and good analgesia and hyperextension bracing and drugs to treat osteoporotic. The drugs mainly we consider NSAIDs, but we should keep in mind cardiac or renal complications. We can consider opioid drugs, but should consideration about sedation and respiratory depression in old patient. We can use calcitonin and other pharmacotherapy. Calcitonin is an endogenous hormone that regulates calcium homeostasis, and it having good analgesic capacity but weak anti-osteoclast action, osteoclast actions. And the paper showing that calcitonin significantly reduces the severity of the pain due to osteoporosis. in pharmacotherapy should be supplemented with calcium 800 to 1200 milligram per day, vitamin D supplementation 800 to 1000 units per day, combination of bisphosphonate and teripeptide, hormonal agents, and other agents like strontium relinate. And in bisphosphonate, they act by inhibiting osteoclastic activity. They can be given orally like alendronate, risodronate, iberdronic acid, and can be given intravenously like pamidronate, zoledronic acid. And they are playing important role in fracture healing by osteoclastic actions. Terapeptide is a newer drug, recombinant human parathyroid hormone that induce bone formation. All other agents we are discussing are anti-resorptive agent, but this is bone forming agent and increasing bone mass. Okay. This paper showing the effect of bisphosphonate associated with they delay the bone remodeling and can delay fracture healing, while teripeptide this is increase bone mass and induce new bone healing, and they involve anabolic effect on stimulate bone formation and activate bone remodeling, improve microarchitecture of trabecular bone, cortical bone, and thus overall increase bone mineral density and both vertebral and non-vertebral fractures. This paper showing support of in terapeptide, showing good result of in pain relieving as well as fracture healing. And vitamin D. Now, management of the osteoporosis include bed rest, bracing, and we can give to pain relief selective nerve root block, L2 nerve root block, and then physiotherapy. And there are some sort of vertebral augmentation like vertebroplasty, kyphoplasty, and surgical stabilization. And bed rest associated with some bad effect like muscle atrophy, psychological impact, and increased comorbidity. And so in these cases, short as possible period of bed rest should be followed like 3 to 4 weeks, and then gradual immobilization with associated with external orthosis should be given. In bracing, there are so many bracings like Wellers brace, hyperextension bracing, dynamic bracing, total contact bracing, and after initial period of bed rest with orthosis, we should also go for a physiotherapy. In physiotherapy, involve normal balancing exercises and strengthening exercises. They generally improve the bone mineral density and prevent further osteoporosis. And there is a definitive role of selective nerve root block in L2 nerve root dorsal root block in fracture of L3 and osteoporosis to reduce pain, but these effects are short-lived. We can repeat blocks. So oral conservative treatment depend on these things: adequate analgesia in the form of medications, calcitonin on a root block, then short bed rest, associated short bed rest with bracing, then physiotherapy and psychological effect. We should consider moral booster of the patient, and simultaneously we should treat the osteoporosis with vitamin D, calcium supplementation, or medications like terapeptide, donation of bisphosphonate. At present, terapeptide is a best drug, having bone formation potency than denosumab and bisphosphonates.
Thank you, Praveen. This is very important topic and is of most interest to orthopedic surgeon who is practicing in periphery. The biggest question comes to his mind is about bed rest. When there is a fracture, the bed rest is prescribed. So how long and how intense? Does it has to be absolute bed rest, or what will you allow to your patient to do?
So what I do, I prescribe my patient bed rest till the pain subsides and it is bearable, and then mobilization with brace for toilet needs. and while doing feeding. And I do a weight bearing standing lateral X-ray with brace in situ. And if there is no further collapse, then I advise them mobilization, so as to minimize the bed rest and its side effects, and to maintain the pain relief.
So what kind of brace do you usually prefer?
It depends on the fracture level of the fracture. If it is in the dorsolumbar junctional area, then I would prefer Taylor's brace, or if a patient can afford, then custom made total contact TLSO. And if it is not possible for him, then ready-made Taylor's brace can be prescribed. If it is in the lumbar area, then simple lumbosacral corset is okay.
Girish, what do you prefer for treating these patients? Denosumab, teriparatide, or bisphosphonates, and why?
Generally, I never use the denosumab. I use the calcium as well as vitamin D3, calcirol sachet or the Lumia 60K or any other drug. And with the calcitonin. Calcitonin has a very good results in bony pain or the fractured pain. And there is a study that if we are using alone the calcitonin with the 200 international unit per day, it has the same results with the 100 international unit calcitonin with the calcium. So I always use the calcium, calcitonin, and teriparatide with vitamin D3. And I have no experience about the biologics like the decimalev and the other things.
So, are you bothered about fracture healing effects of bisphosphonates? Do you think that they actually inhibit the fracture healing or delay the fracture healing?
No, alendronate and these are the basically anti-resorptive agents, and only the bony agent is the teriparatide or the decimalev. So I use the teriparatide for the bony healing, and the bisphosphonates use as an anti-resorptive and decrease the osteoclastic activities. So I never fear about that using the bisphosphonates and the teriparatide simultaneously.
Ashish, your take on these things?
Actually, there are a lot of controversy about using anti-resorptive in an acute fracture state. But since we have teriparatide, so I think first line of drug is teriparatide. And once we continue it for prescribed period of around 2 years, then we can do maintenance treatment with denosumab or biphosphonates. So that is the thing. Very rarely, if it is heavily, very severely osteoporotic, then maybe we need to combine both. Otherwise, teriparatide is the drug of choice.
And how soon you mobilize your patients?
For mobility, is just pain is the restricting factor. I never advise bed rest. I will prefer, because prescribing a bed rest in an elderly patient is not at all advisable. Maybe means, if you have to wait for at least 6 weeks, which is not at all advisable. So I prescribe no bed rest, but if patient is not tolerating pain, then maybe for that factor, he or she may take bed rest.
So very important message.
I'd like to add a point.
Yeah, Chirag, please.
One, we need to have a confirmed diagnosis that we are dealing with a primary osteoporosis before thinking of giving teriparatide.
That's important. Since we were, that is very, very important.
I would ever give teriparatide on the first day. If suppose the patient comes to you with a history of a injury, a day back or 2 back, I would definitely not straight away jump into that. Treat them with a cocktail which you mentioned. I would definitely do a bone mineral density test, either a DEXA or a quantitative CT, whichever is available. So when you mentioned about sending a patient for CT, so for any reason, if you're sending a patient for CT, then you can always ask them to do a bone mineral density, which will be more authentic than the one which you get on a DEXA scan. Otherwise, calcium, vitamin D, calcitonin is useful for acute bone pain relief. I'm not a very big fan of the Taylor brace. So if you really ask me whether most of the patients don't tolerate it, or it's so loose that whether it's actually doing its job or not. So, I mean, you'll have to look at the patient's skin condition, how they are, their obesity and everything, and then probably take a call on the bracing. even a lumbar sacral belt. You just need to give some pain relief. Neither the Taylor brace nor the TLSO is going to do much about treating the fracture. So that is what I usually do, and definitely not teriparatide on day one. If you have a long history with multiple level osteoporotic fractures, very low MD, then yes, but not for a single level first timer patient who comes to you and just jump into giving teriparatide as a first line of treatment.
Can I add some point?
Yeah, please.
Yeah, for the teriparatide and bisphosphonate, actually both have different mechanism of action. Bisphosphonate is a catabolic therapy and teriparatide is an anabolic therapy. Never mix both of them. If one has started the bisphosphonate, then before starting the teriparatide, there has to be a drug-free interval. So both therapy together is not advised. Second thing is regarding the bracing. Bracing is a clear funda. If the fracture is L1 or below, lumbosacral orthosis is good enough. And if the fracture is above the L1, then dorsolumbosacral orthosis is required.
The problem is like if we advise patient a total contact TLS, so it becomes extremely uncomfortable in our climatic conditions.
See, for that thing, like dorsolumbosacral orthosis doesn't mean the APTLS. So dorsolumbosacral orthosis means Ash brace, Javid brace, Taylor's brace, only posterior dorsolumbosacral orthosis. There are many variants of the dorsolumbosacral orthosis. Yeah. So for the vertebral osteocompression fracture, mostly Ash brace is advisable because it decreases the chances of kyphosis.
But I think, Darshan, there are many studies which now say the combination of using teriparatide with denosumab, teriparatide with zoledronic acid. So I'm not sure whether you need to have a drug-free interval to my knowledge. There are n number of studies which have shown a combination of two being used.
But principally both have different mechanism of action.
No, but both add on. That is advantage, that both add on. If it is a Lalit?
I think this is a very big controversial topic. That's why I started this. So the goal is, the basic understanding is that we need to treat osteoporosis. For sure, don't just leave the patient once the fracture is healed. You must tell the patient that he or she requires a long-term treatment, whether it is anti-catabolic, whether it's anabolic, whatever suits the patient's requirement and whatever is available, because there are multiple issues in that. So there are few things are clear. Bracing, if tolerated, should be done, should be given. The patient should be mobilized as early as possible, because the prolonged bed rest will actually start a vicious cycle of precipitating more osteoporosis, which would cause again a fresh fracture and again bed rest. So this cycle needs to be broken. So never advise a prolonged bed rest, advise brace and do whatever treatment you want to do for osteoporosis. Now we'll go ahead and see the surgical management part of vertebral compression fractures. Dr. Naveen?
Yes, sir.
Yeah, please go ahead.
Yeah, good afternoon. Here, I would like to add a point which sums up our previous discussion as well as will include our discussion if we move forward. See, here we are dealing with a problem which is a medical condition. We are dealing with a medical condition. We are dealing with its complications. In short, we are dealing with complications related to a medical problem. So it's very important to treat the osteoporosis itself, and surgical management rather plays a very small role. It comes into picture only when there's only when the pain is incapacitating. The pain becomes the most important factor when we talk about surgical management. And since our patient population is elderly, they have many comorbidities and there are high chances of implant-related poor bone quality. So it's better if we can avoid it. It can be avoided. So to shorten the complication rates of surgery, fewer percutaneous procedures have come into work, like vertebroplasty and kyphoplasty. These are the main mainstays in surgical management. So being minimally invasive, they require just local anesthesia and just minimal blood loss. In vertebroplasty, there will be injection of PMMA cement, although there are other substitutes available, but not routinely used. So these are done under fluoroscopic guidance with the use of needles. So how does it work? It provides mechanical stability at the site of fracture, as well as to reduce the pain. The mechanism which causes reduction in pain is, it's hypothesized to be that the cement leads to an exothermic reaction, which desensitizes the nerve endings and causes pain relief. There's no perfect, no proven study to say how there is pain relief, but it is hypothesized that it desensitizes the nerves around the fracture, and also it provides some mechanical stability, which in itself will reduce the pain. So, but still, there have been studies which say placebo. There have been studies which say that some patients were put under. Were taken into OT, put prone, and they were not injected with cement, but yet they managed to have some pain relief. So even there are studies like this available. So
we need to fasten up.
Yes.
Yeah.
Yes, sir.
We need to speed up.
Yes. When do we do vertebroplasty? It's like as I said earlier, that the pain is the most important factor which guides us to the management. And it's usually done in chronic cases, like the patient is being treated conservatively, but there's no pain relief for say 4 weeks, 6 weeks, and he still comes with a pain. So then and he wants to get mobilized. In such condition, in such cases, we can plan for surgical management. We can plan for vertebroplasty or kyphoplasty. Vertebroplasty is associated with many complications. The major complication being leakage. So the leakage is mainly, it is postulated to be up to say 65% of there have been studies which say that there's up to 65% chances of cement leakage. And it is dose dependent. The higher the dose you use, the more the chances of leakage. And there can be other sequels of leakage also, like pulmonary embolism and all. The other complications would be fracturing the posterior elements while inserting the needle, damage to nerves, and pneumothorax infection. And there's this X-ray. It clearly shows how the cement extravasating into the superior and inferior end plate, which should be avoided. So there's been studies which show. So can we move to next one? Yeah. This picture clearly shows how there can be pulmonary embolism. Now coming to percutaneous kyphoplasty. So it is same as vertebroplasty. The indications will be similar to vertebroplasty. The only thing will be that there will be an additional balloon angioplasty. There will be insertion of balloon through the same portal, the transpedicular portal. And that balloon, when inflated with dye, helps to restore the height of vertebral body and gives enough space for the extra cement to be put into it without risking the leakage part, which is associated with vertebroplasty. But the major disadvantage with kyphoplasty would be the higher cost. The cost might go up to say 6 to 7 times when comparing it to a vertebroplasty. So in our scenario, that becomes a major issue. Now, this chart very nicely depicts the differences between both the procedures. The pain relief is almost similar in both the cases. The major difference comes into higher complication rates with vertebroplasty and higher costs associated with kyphoplasty. And also, kyphoplasty per se can help to reduce the deformity, which is an additional advantage of kyphoplasty, which is absent in vertebroplasty. In vertebroplasty, the deformity correction is mainly because of the positioning part. And in kyphoplasty, it actively reduces the deformity by expanding the body and achieving the natural height of the fractured body. So the major contraindications associated with these procedures would be coagulopathy, presence of some neurological deficits, bleeding diastasis, allergic to PMMA, and fractures, and of course fractures of the posterior vertebral wall. This would be a major contraindication in whenever there is a posterior vertebral wall fracture. The risk of cord injury would be very high. It's better not to touch these procedures in such. So here there's a patient, and this patient had come to me with a L1 compression fracture. The body height had reduced, was like say more than 50% loss of vertebral body height, and the symptoms were on for around 6 weeks. I put him on conservative management for 6 weeks. I've given him everything, all the regimes which we have talked about in the last session. But there was no pain relief. There was significant pain. So then I taken this patient for kyphoplasty. This picture shows how we localize the pedicle. The entry point, we'll have to confirm it under AP as well as lateral views. In AP view, the point of the entry is somewhere around lateral and superior corner of the pedicle, and in the AP view. And in lateral trajectory, we have to aim it almost parallel to the superior end plate. So, I mean, after positioning it, we tend to hammer and insert the needle. And then you can see a guide wire which is inserted over the needle, the cannulated needle which we had inserted initially. Now the needle has been removed, and then we start putting the working channels which come with the kyphoplasty setup. So after putting the channels, we remove and we put a balloon. Here we can see that there are the 2 dots which are visible. This is the length of the balloon. These signify that, what point a balloon has entered. So the length would be say around 15 to 20 mm, and volume would be 4 to 6 cc depending upon the length of the balloon which we have used. And the ideal placement would be anterior 2/3 of the body, which can be seen in the next slide. Here we can see that the dye, don't get confused with the additional shadow which will be seen anterior. It was just a problem during the procedure, so our dye had gone extravasated anteriorly. So here the the inflated balloon can be seen. The important point is, when do we have to stop inflating it? There should be some endpoint, otherwise it will burst inside the body. So there are 3 major endpoints. Whenever we have achieved the height, there's been cortical context, or the pressure has gone above 250 psi. So these pressure markings will be there on the kyphoplasty setup. Pressures can be seen. So, now then the dye is removed, balloon is deflated, balloon is removed, and now we start injecting the cement. So here we can see the cement block which has been put to the same working cannula. So this is the basic procedure how we do a kyphoplasty, and this can be done unilateral as well as bilateral, but it's better to do it on both, use both the pedicles if you want to get a good height and restoration of body. These are the small incisions and minimal blood loss under local anesthesia.
Very good, Naveen. Chirayu, what would be your indication? What would be your timeline when you will suggest the patient to go for cement augmentation procedure?
See, Lalit, sometimes it is very difficult to know the timeline because these patients may have a history of fall or they may not have a fall. But definitely I would give conservative treatment of not less than 6 weeks, maybe wait till 12 weeks. Teriparatide is a wonderful molecule. To be very frank, my rate of vertebroplasty has gone down significantly in the last 2-3 years. But if I see a Hummel sign or a non-union classically on the CT or the MRI, and then I will talk and counsel the patient, because this is not a procedure which is going to do very wonderful things. It may give you pain relief for some time, but it is not something which is going to take care of everything. You must have seen your patients who've undergone vertebro. I don't do kyphoplasty at all, so I will not talk about that. But vertebroplasty, I'm not sure that it gives you that amazing results. It does give you pain relief. So if there is really a cleft or a non-union, and then only I would definitely counsel the patient. I will give the full trial of medical treatment. I think all these biologics do much better results. Yeah.
So, but if we have decided, then yes, these signs have to be there to do that.
Yeah,
I think the dynamic X-rays, the erect X-rays, I think have a more role after you've treated them conservatively, and then you look for those signs of non-union.
Yeah.
This presentation didn't have those X-rays. I mean, the pre-operative X-rays and MRI films. I mean, I'm not able to share my screen. Otherwise, I would have shown you how the films were before the procedure.
So we'll discuss one case here. She was a 74-year-old female who presented with back pain from 6 weeks, which was progressively worsening. A very poor general profile of the patient. She is a known case of CKD. Creatinine is 4.2. She is a known case of triple vessel disease. Her LV ejection fraction is left ventricular ejection fraction is only 20%, and poorly controlled diabetes. HbA1c is 9.8, and now from last 1 week, she is unable to walk and pass urine. So a difficult case, and this is the X-ray. So Naveen. Hello.
Yes, sir.
Naveen, would you like to comment on this X-ray?
So here I can see L1 compression fracture.
Yeah.
With, anterior wedge and air cleft.
Yeah.
Can be clearly seen in both the views.
Yeah. So this is what you can call a Kummel sign type of thing, a vacuum cleft.
And associated other degenerative changes also can be seen here.
Yeah. And if we notice carefully, there is also another fracture at L3 level.
No.
And this is the MRI. So, Namit, Chirayu, have you seen something like this?
Yes.
Girish?
Yes, sir. Basically, there is a hyper-intense image in the T2 as posteriorly at the level of L1.
Yeah.
So this may be some tumor-like structure and the compressing the spinal cord as well, because it is the level of the L1. So, sir, what was the clinical presentation of the patient? She was not able, and how was the neurological sign?
Neurological findings on X-ray, basically the patient is, neurologically patient is fine, but she is unable to walk. We don't know whether it's because of pain or whether it's because of deficit.
Okay, so there was no any spastic or the UMN sign?
No.
Okay.
So this is the axial MRI where you can see a cystic lesion, and actually on evaluating further, I found that this cystic lesion was actually originating from right right facet joint.
That's it.
So Ashish, your take.
This emphasizes why even in a present of classical sign, we should still do MRI. Because sometimes if patient is poor and we may get carried away to avoid MRI. So this is very, very important.
We already have MRI. I think it's shown the MRI. So,
Yeah. This just what would you do? Emphasis like.
Yeah. Okay. So what's next?
What you do?
That is an important thing. So neurological signs are not there.
Yes.
So maybe we will have to do a contrast MRI.
Yeah.
Next, and then accordingly we can decide. Maybe I can give an option because it is a very high risk case. So still I may go with vertebroplasty and explain the thing to the patient that he may need intervention for the posterior thing.
Chirayu?
For immediate mobilization part, we may consider vertebroplasty, but for this cyst part, we have to decide later what we need to do.
I would rather do both together. I would do a percutaneous vertebroplasty because this is a very high patient. I am not sure whether this patient is ever going to be fit for any kind of a surgical intervention. And in addition, you can go for a cyst or a cyst respiration through the needle as we do for facet cyst, and then probably hope for the best.
Sir, my take is because she is having difficulty in urination, simultaneously she is having compressive lesion at the conus level, which may correlate the things. And most probably this is a facet cyst due to instability. There is intravertebral instability. Simultaneously, if you see there is cyst coming from the facet. This is suggestive of instability, so it has to be stabilized. Regarding the patient's comorbidities and high risk of surgery, first we can do this kyphoplasty, and then at the same time we can attempt aspiration of the cyst under Siam guidance with the facet injection of the radio opaque material. If we are successful, then it's okay. If not, then we have to go for open surgery.
Darshan, would you go for kypho, vertebro, or open surgery?
Sir, for this particular case, stabilization. And before stabilization, for bladder thing, we can evaluate the patient. See, lesion, Praveen has rightly mentioned that lesion has conus and bladder symptom is there. So we can do pre-void, post-void ultrasonography, we can do urodynamic study. And if it is a urogenic bladder, then it will not subside, it will not improve by the vertebroplasty or the kyphoplasty. So evaluation of the bladder symptom is needed, and if it is as in MRI, it is neurogenic only, then surgery is required. Either don't do anything or to operate.
So I went the way Chirayu told, and I did the percutaneous kyphoplasty, and I put a needle. If you can see in this image, I put a spinal needle 23 gauge through interlaminar space, and I approached the cyst and I aspirated the cyst. It has been, I think, 1 month after surgery. We have not got any repeat scan done till now, but the patient is clinically doing wonderful. She is independent ambulator now, and her urine control is gained back. So this was a debatable type of case. So yes, there would have been no comorbidities. Yes, I would also have gone for fixation.
Yeah.
Wonderful.
Yeah, that's a nice.
Excellent.
Nice case, Lalit.
Nice case. Very wonderful.
So, Lalit, all your kyphos are under local anesthesia?
Yeah, all my kyphos are under local anesthesia. All my kyphos are more or less unipedicular, and I very rarely go bipedicular. So it's under local with mild sedation. That's it.
It is very difficult to aspirate the cyst which is within the spinal canal from the posterior side.
Yeah.
Yeah, it is very difficult.
Yeah.
Sir, did you use a radio opaque material to confirm that you are in the cyst or?
No, I decided not to inject anything because if I'm in the dura, because this more harm actually.
Already if you will inject anything, then there may be some arachnoiditis or like.
Yeah, patient is awake. So I just approached and I aspirated. I just correlated the MRI.
The needle position.
Yeah, needle position. That's it. So Praveen, now I request you to start your case.
Okay, sir. So are you sharing or should I share?
Yeah, you can share, no issues.
Lalit, I think we need to wind up in another 5 minutes. So probably I just got a call from Dr. Rahul and everyone. So I think so So Praveen, you have to become Shatabdi Express.
Yeah, this is a case similar to sir, but it has a 64-year-old female. She is a known case of diabetes, hypertension, and 20 years CVA. Means she has CVA 20 years back and has left-sided residual hemiparesis, and she is obese. She is limited household movement. She has limited household movements for last 20 years. She sustained a fall while standing up from the bed 4 months back, and started having back pain, was managed conservatively with bed rest for 1 month, and then started mobilizing, and gradually the pain was worsening, and now patient presented to me with severe back pain which was radiating anteriorly to the ribs, and she has inability to sit even for 2 minutes, and there was weakness in both the lower limbs and severe constipation and pain relief on supine position. So on examination, patient has a tenderness over the D12 vertebra, and on neurological examination, she has great.
Sorry to interrupt, but we need to go to X-rays.
Okay, sir.
Yeah.
So this is the X-ray.
Yeah. So just tell in short, what are your findings and how you manage this patient?
There is a vacuum sign in the D12 vertebra, and there is an old healed collapse of D11 with disc-like lesions in the above levels. This is the MRI. We can see a fluid density in the T2 weighted images in D12 level, where the cord is impinged by the fracture fragment. This is the stress sequence, and this is the T1 sequence. You can see the pictures. So this is the axial images. There is a fluid sign in the D12 level and cord compression at the same level. Lumbar spine MRI. So we have a diagnosis of D12 Kummel's lesion which is a pseudo-arthrosis in vertebral compression fractures with cord compression, old heels, old CVA left side, and diabetes, hypertension, obesity. So what are the management options? What we should do in such case? Whether we should continue the conservative treatment, or we should go for a kyphoplasty, or we should fix it, or we should do a combined job fixation or kypho and vertebro, or rather than fix kypho, we should go for autografting or fix corpectomy, discectomy, anterior column reconstruction like this, or anything else. And other questions are whether we should go for an fixation, how many levels, types of screws, types of rod or cross connector. Sir, Giri sir, do you want to?
Though the patient has the stroke comorbidity, so I will go for a preference for the cement augmentation only. And though patient also has a posterior compression, so I will be aware about the cement during the cement augmentation about the leaking.
Okay, sir. So Darshan sir, your opinion.
Praveen, with the neurological deficit and posterior cortex, the posterior vertebral body cortex is fractured. So posterior pedicle screw fixation, decompression, and deal with the fractured vertebrae with the vertebroplasty.
Nambit, your opinion?
Yeah, I will go for posterior fixation and decompression and D12 transpedicular bone grafting.
Okay, so we'll go ahead. This is a simple classification system which can guide people whether to go for surgery or not. This is very similar to Telix score, and it is especially designed for osteoporotic fractures. If we calculate the score in this patient, this is a burst fracture with vacuum sign and bone density because it is already osteoporotic. It's and multiple fractures. The bone density should be 1 or 2, and she is having severe back pain, so the total score comes to around 7. So continuing the conservative treatment is not recommended. We should go for intervention. So this is also important slide where conservative treatment is likely to fail. There are poor prognosis with conservative treatment. There is a certain fracture patterns of osteoporotic vertebral compression fractures. So they say swell front type and bow shape type and projecting types are have poor prognosis. So they need early intervention. As sir said, there are some indications for posterior fixation along with vertebroplasty or kyphoplasty, such as there is PLC injury or posterior bony lesion, fractures of hand plate, or use of calcium phosphate cement in place of PMM cement. Yes, sir.
We'll be going offline soon. Show
Okay,
what
sir.
was done.
Okay, sir. So we have done a cage plasty in this case. What we have done, because there is a large huge gap, this is the Siam image. If you see on prone positioning, it was opening wide and cement holding was very difficult in such cases, and leakage is very common. So we have done a cage plasty. We have curated inside the bone the defect, and then put a cage through the pedicle, transpedicular route, and this is the fixation attained. And the screws were augmented by the cements.
Very good.